Okay, let's really dig into these practice questions you've been working through. Pinpointing why certain answers felt right but weren't quite the bullseye, that's really where the understanding deepens, isn't it?
Exactly. It's about dissecting those nuances, understanding not just the facts, but the principles underneath,
Right. Helps build a stronger framework for next time.
for sure. Makes it stick better.
All right, let's dive into the first one then. Here's practice question one. A 55-year-old woman with a history of metastatic melanoma presents to the oncology clinic for follow-up. She recently started on high-dose interleukin-2, IL-2, therapy. On examination, the patient reports fatigue and mild shortness of breath, but her imaging studies show a marked reduction in tumor size. Which of the following cellular mechanisms is most likely responsible for the observed tumor regression in this patient?
Okay.
The correct answer here is C, increased cytotoxic activity of natural killer cells. So let's break down why that's the one.
Right. So high dose IL-2, the key thing is its effect on lymphocytes. It's a major growth factor, particularly for NK cells.
NK cells, okay. Natural killer cells.
Yeah. And it doesn't just make more of them, it really amps up their killing ability, their cytotoxicity.
So they're more aggressive.
Exactly. And NK cells, remember, are part of the innate immune system. They can recognize and kill certain tumor cells without needing prior sensitization, unlike T cells sometimes.
So they can act fast,
Hmm.
which fits with the marked reduction in tumor size mentioned.
Precisely. That rapid response, that direct killing without complex pre-activation steps, that's very characteristic of what high-dose IL-2 does via NK cells.
Okay, got it. So let's look at why the others aren't the best fit. Option A was activation of regulatory T cells.
Right. Dregs. Well, they do the opposite, don't they?
Yeah, they suppress the immune response, keep things in check.
Exactly. Put the brakes on. So activating them would actually work against clearing the tumor. You'd expect less tumor regression, not more.
Okay, that makes sense. Definitely not A. What about B, enhanced proliferation of B cells?
B cells are crucial, obviously, for antibodies, humoral immunity.
Right, making antibodies.
And while antibodies can play a role against tumors, like through ADCC,
Mm-hmm.
antibody-dependent cell-mediated cytotoxicity.
Where they flag the cells for destruction.
Yeah. But that's generally not considered the primary mechanism for the dramatic effect we see with high-dose IL-2 therapy like this. The direct NK cell killing is thought to be much more significant here.
So B cells are more secondary in this specific context.
In the context of high-dose IL-2's main effect, yes.
Okay. And the last wrong one, D, directs tumor cell apoptosis via IL-2.
Yeah, this is a common misconception. IL-2 itself doesn't just, walk up to a tumor cell and tell it to die.
Uh-huh, right. It's not a direct poison.
No, it works indirectly.
Right.
It empowers the immune system, primarily those NK cells, and also cytotoxic T lymphocytes, though NKs are key for this question's scenario to do the killing.
Right.
The apoptosis happens, but it's mediated by the immune cells IL-2 activates.
Got it. So IL-2 is the coach, not the player hitting the home run.
That's a good way to put it. It boosts the immune players.
Okay, that clears up question one nicely. Let's move to the next one. Here's practice question two. A 16-year-old female presents to the clinic with concerns of primary amenorrhea. She reports normal breast development and pubic hair growth. She has no significant medical history and denies any medications or substance use. Her physical examination reveals normal secondary sexual characteristics and a normal external genitalia. Laboratory tests show normal levels of estrogen and testosterone. A pelvic ultrasound reveals the absence of a uterus, but normal-appearing ovaries. What is the most likely diagnosis?
Classic presentation.
And the correct answer is C, Mullerian agenesis. So walk us through this one. What points directly to Mullerian agenesis?
Well, you've got a female with normal secondary sexual characteristics, breast development, pubic hair. That tells you her ovaries are working, right? They're making estrogen and androgens.
Okay, yeah. And the labs confirm normal estrogen and testosterone. And the ultrasound shows ovaries.
Exactly. But she has primary amenorrhea, never had a period, and the ultrasound shows no uterus. So the problem isn't the hormones or the ovaries. The issue is the structure needed for menstruation. The uterus isn't there. This points squarely at a developmental issue with the Mullerian ducts.
Which form the uterus, fallopian tubes, upper vagina.
Precisely. In Mullerian agenesis, also called MRKH syndrome, those ducts just don't develop properly. But since the ovaries develop separately, hormone production and secondary sex characteristics are usually totally normal.
Okay, that fits the picture perfectly.
Yeah.
Now let's rule out the others. A was Turner syndrome.
Right. Turner syndrome is 45XO. The key issue there is usually ovarian dysgenesis. The ovaries don't develop properly or are streak gonads.
So low estrogen.
Yep, low estrogen, which means you typically don't see normal breast development. You often see short stature, webbed neck, other physical signs.
Yeah.
Our patient has normal development and normal ovaries, so Turner's is out.
Makes sense. What about B, androgen insensitivity syndrome, AIS?
AIS is interesting. These individuals are genetically male, 46XY, but their bodies can't respond to androgens.
So testosterone doesn't work properly.
Right. They develop female external genitalia. And because testosterone gets converted to estrogen, they do get breast development.
Okay, so far sounds a bit similar.
But crucially, because they can't respond to androgens, they typically have minimal or no pubic or axillary hair.
And our patient had normal pubic hair.
Exactly. Plus, AIS individuals don't have a uterus because their testes do produce anti-Mullerian hormone. But the key differentiator here is the pubic hair, plus the karyotype difference and presence of testes instead of ovaries.
Okay, so the pubic hair is a big clue there.
Got it.
Lastly, D, Swyer syndrome.
Swyer syndrome is also 46XY, but there's a problem with the SRY gene on the Y chromosome, so testes don't develop. Instead, they have streak gonads.
Like in Turner's.
Similar outcome with the gonads, yes. Streak gonads don't produce much hormone, so no testosterone, very little estrogen. They won't develop secondary sexual characteristics spontaneously. No breasts, no periods.
And again, our patient has normal development.
Right, so Swyer syndrome doesn't fit either. The combination of normal female development, normal ovaries, normal hormones, but no uterus, that's really classic Mullerian agenesis.
Excellent breakdown. Understanding the embryology and the hormone profiles is key. Okay, on to practice question 3. A 3-month-old girl is brought to the pediatrician by her parents who are concerned about her persistent lethargy and poor feeding. The family recently moved from a rural area in Southeast Asia to the United States. The infant was born at term via an uncomplicated vaginal delivery. Her parents note that she has been sleeping excessively and is difficult to wake for feedings. They also mention that she has been constipated, with bowel movements occurring only every 3 to 4 days. On examination, the infant appears lethargic and has a puffy face, dry skin, and a protruding tongue. She is hypotonic and has a large anterior fontanelle. Which of the following is the most likely diagnosis?
Okay, a young infant, lethargic.
The answer is C, congenital hypothyroidism. This presentation seems quite striking.
It really is. This constellation of symptoms, the lethargy, the poor feeding, constipation, the floppy baby hypotonia. Then you add the physical signs. Puffy face, dry skin, that protruding tongue, the large fontanelle. It almost screams congenital hypothyroidism.
So these are all classic signs of low thyroid hormone in an infant.
Absolutely. Thyroid hormone is critical for, well, almost everything early on. Metabolism, growth, brain development. When it's low, things slow right down. Hence the sleepiness, constipation, poor feeding. The physical features are also very characteristic.
And the family history detail? Moving from Southeast Asia.
That adds another layer, potentially. While thyroid dysgenesis, the gland not forming right, is the most common cause worldwide, iodine deficiency is still a major cause in some regions, including parts of Southeast Asia. So it raises the possibility of iodine deficiency as the underlying cause. But regardless of cause, the clinical picture points strongly to hypothyroidism.
Makes sense. It's crucial to catch this early, right?
Oh, absolutely critical. Untreated congenital hypothyroidism leads to severe developmental delay and intellectual disability. That's why newborn screening is so important.
Okay, let's quickly run through the distractors. A, congenital adrenal hyperplasia, CAH.
CAH is about adrenal steroid synthesis. Usually you're thinking about ambiguous genitalia in girls or salt-wasting vomiting, dehydration, electrolyte problems, or maybe later precocious puberty. It doesn't typically cause the specific set of hypothyroid features like the puffy face and protruding tongue.
Different pathway, different symptoms. Got it. B, cystic fibrosis.
CFT primarily hits the lungs and the GI tract. Thick mucus. So you think respiratory infections, maybe meconium ileus at birth, failure to thrive despite a good appetite sometimes. Not really this picture of profound lethargy in those specific facial features.
Okay. D, spinal muscular atrophy, SMA.
SMA is a motor neuron disease. So yes, you get hypotonia, weakness, progressive weakness.
But the other stuff doesn't fit.
Right. Infants with SMA are typically alert, maybe even bright-eyed, especially early on. They don't usually have the constipation, puffy face, dry skin, protruding tongue of hypothyroidism. The lethargy here seems beyond just muscle weakness.
Okay. And finally, E, maple syrup urine disease,
MSUD is an inborn error of metabolism, affects branched-chain amino acids. It presents very early, often first few days of life, with poor feeding, vomiting, severe lethargy progressing to coma, and that characteristic sweet maple syrup smell in the urine.
Ah, the smell is key.
It is. And while there's overlap with lethargy and poor feeding, the overall picture and lack of that specific odor points away from MSUD and strongly towards hypothyroidism in this 3-month-old.
Hey, the pattern recognition for congenital hypothyroidism is really important there. Great. Last one. Here's practice question 4. A 5-year-old girl is brought to the clinic by her parents due to fatigue and poor appetite. She has been irritable and has had difficulty walking. On examination, she appears pale and has a rapid heart rate. Laboratory tests reveal a macrocytic anemia and elevated serum lactate levels. A dietary history reveals that the family follows a strict vegan diet without vitamin supplementation. Which of the following enzymes is most likely to have impaired activity in this patient?
All right, a few key pieces here. Vegan diet, macrocytic anemia, high lactate.
And the answer is pyruvate dehydrogenase. Connect the dots for us. How does the diet lead to this enzyme deficiency?
Okay, so strict vegan diet without supplements immediately flags potential deficiencies. The big ones are often vitamin B12 and potentially iron, but also thiamine, vitamin B1.
Right. B12 causes macrocytic anemia.
It does, but B12 deficiency doesn't typically cause elevated lactate levels. That points towards a problem with energy metabolism.
And that's where thiamine comes in.
Exactly. Thiamine pyrophosphate, the active form of B1, is a absolutely essential cofactor for several key enzymes in carbohydrate metabolism, including pyruvate dehydrogenase, or PDH.
PDH, that's the enzyme linking glycolysis to the citric acid cycle, right?
Yeah.
Converts pyruvate to acetyl-CoA.
Precisely. If you don't have enough thiamine, PDH activity slows down. Pyruvate can't enter the citric acid cycle efficiently, so what happens?
Pyruvate builds up,
It builds up, and the body tries to deal with it by converting it to lactate via lactate dehydrogenase.
leading to lactic acidosis, hence the elevated lactate.
Yep. And the lack of energy production contributes to the fatigue, irritability, maybe even the walking difficulties. Think neurological symptoms of thiamine deficiency, like beriberi. The macrocytic anemia could be coexisting B12 deficiency from the diet, or thiamine deficiency itself can sometimes contribute to anemia, though B12 is more classic. But the lactate really points the finger at a thiamine-dependent enzyme.
So PDH is the most likely enzyme affected given the thiamine link in the lactate.
Okay.
Why not A, ornithine transcarbamylase?
OTC deficiency is a urea cycle disorder. It causes hyperammonemia buildup of ammonia. That leads to neurological symptoms, yes, but not typically macrocytic anemia or lactic acidosis. Wrong pathway.
Okay. How about B, pyruvate carboxylase? It also uses pyruvate.
It does. Pyruvate carboxylase converts pyruvate to oxaloacetate, important for gluconeogenesis and replenishing the citric acid cycle. Deficiency can cause lactic acidosis and neurological problems.
So why not that one?
It's less directly tied to thiamine deficiency. Pyruvate carboxylase uses biotin as a cofactor, and while it causes lactic acidosis, the strong dietary clue pointing towards thiamine makes PDH the more probable affected enzyme here, especially given the whole clinical picture, including potential neurological signs suggestive of beriberi.
Okay, the thiamine link is the strongest connection. Got it. And D, succinate dehydrogenase.
SDH is part of both the citric acid cycle and the electron transport chain, complex 2. Deficiency messes up energy production, can cause lactic acidosis, and various neurological issues, sometimes tumors like paragangliomas. But again, there's no direct link to thiamine deficiency.
And it doesn't usually cause macrocytic anemia either.
Not typically as a primary feature, no. So putting it all together, the vegan diet, the potential thiamine deficiency, the high lactate, the macrocytic anemia, the neurological symptoms, impaired pyruvate dehydrogenase activity fits best.
Wow, yeah. Seeing how that one dietary factor can cascade down through a specific enzyme cofactor to cause such a distinct set of symptoms and lab findings is really quite something.
But it really highlights the interconnectedness, doesn't it? Biochemistry in action.
Definitely. Breaking down these missed questions, understanding the why behind the right answer and the why not for the others, it really solidifies things.
It's the best way to learn from mistakes. Keep doing that detailed review.
Will do. And it's fascinating, isn't it, how these cases, presenting sometimes quite differently, can all loop back to these fundamental biochemical or, immunological principles we learned.
That's the beauty of it. Seeing those connections is key.